Speaker of the day, Dr. Jyotsna Oak. She is consultant rheumatologist and physician at Dhirubhai Ambani Hospital, Mumbai, formerly professor and in charge rheumatology at LT MG Sion Hospital, Mumbai. She is going to talk on treatment aspects of SLE. एक मिनट जरा इधर ही लगाओ एक मिनट पॉइंटर किधर है
Very good morning to all of you. First of all, I would like to thank the Chandra Institute and the directors Dr. Dharmanand and Dr. Chandrasekhar for inviting me here for this Chandra update program. One of the big topics in rheumatology is systemic lupus erythematosus, and basically it is because of its diversity of symptoms, varied manifestations, and lot of times even the rheumatologist can be confused looking at the different manifestations of systemic lupus erythematosus. Today what I would be doing in the next few minutes would be giving you a brief idea as to how the patients of SLE would look, how you would try to come to a right diagnosis, reasoning out that most probably the patients could be having SLE, and then decide upon the best management which could be suited to the patient. Living in rheumatology for last so many years, SLE still fascinates most of the rheumatologists because of its different clinical aspects. So SLE in brief is really multi-system manifestations. It's an autoimmune disorder with very different clinical manifestations, and the course could be extremely variable. Unlike rheumatoid, which Dr. Dharmanand has pointed out to you, that you can have the first 2 years or the first few months could be called as early rheumatoid. In SLE, the patients can manifest right at the beginning with very severe clinical manifestations, or it could be like a catastrophic Apla syndrome with SLE. Remissions and relapses are again the backbone of SLE, and you can't predict them always. That is why most of the times the physicians used to feel once you diagnose a patient of SLE, it has a very gloomy outcome. Patients will not survive for a few years, and they used to have a very bad kind of impression in the mind that this patient is not having a good prognosis. But it is not like that. With varied clinical manifestations, still with challenging perspective, a rheumatologist with whatever armamentarium they have can manage fairly well the patients of SLE. They are all young patients in their childbearing age. They are females. They have many issues like childbearing, reproductive, and they want to look good during that stage. They are hit upon by this kind of very bad disease. Whether a protocol-based treatment is possible in SLE, and whether every patient can be managed with a particular protocol is something which is not actually very real in practicing life. So what I will be giving you is some theoretical aspects, and then how practically we deal with all these problems of dealing with SLE. All of you must have known that various autoantibodies are there in SLE. They confuse your life more and more. There are basic antibodies to cell nucleus component like ANA, anti-dsDNA, and then there are antibodies to cytoplasmic antigens like anti-SSA and SSB. And once you have this report of ANA positive, the general trend in the practice is that you can label this patient as SLE simply because the ANA is positive. But it is not like that. We know that in so many other rheumatological disorders like Sjogren's syndrome, scleroderma, and even so many other disorders like rheumatoid arthritis, ANA can be positive. So merely ANA becoming positive doesn't mean that the patient has SLE. ANA is one of the important lab investigations which will support your diagnosis. There could be antibodies not only to the cellular components but other components in the serum like coagulant factors, different cells like platelets, RBCs and WBCs. So SLE has various autoantibodies, and because of which it has got different clinical manifestations. They are actually the pathognomonic role in the whole spectrum of SLE. And these are some of the tests which we used to do when I was a student, perhaps, like LE cell phenomena. It was basically seen in drug-induced lupus and patients who have got antihistone antibodies. The smear used to be flooded with LE cell. Now that we have got immunofluorescence, we don't rely on LE cell anymore, and we don't ask for it. This is a typical homogeneous pattern, a diffuse bright green staining of nuclei which are seen in case of HEP2 cells, because this is a specific substrate we are using as a nuclear component for diagnosing lupus. Any other testing of ANA done either ELISA or any other method is not so specific, even though it could be sensitive. That is why when you are interpreting ANA, please try to see which is the method which is used to interpret ANA. It has to be immunofluorescence technique, and then only you can say that, well, the patient could be having ANA positivity. A rim peripheral pattern, which is a linear pattern, is seen again basically in cases of dsDNA positive, and we know that if dsDNA positive, patient could be having high probability of having SLE. It could be also leading to renal manifestations in case of SLE. Whereas a nuclear pattern is not very specific but can be seen in some of the patients of SLE, and the speckle pattern, which actually is seen in SSA and SSB, and the Smith antigen, you all must have heard. The Smith is more specific for lupus, but only 20 to 30% of patients of lupus could be having Smith positivity. This is just a background as to how you build up your diagnostic skills by using various techniques and then to come to a right conclusion. The Criteria lucili organisms have a very small kinetoplast, and that is why it can be used as the most specific agent for the dsDNA. So again, the dsDNA, you have to see that whether the pathological lab has used Criteria lucili technique or they have used just an ELISA technique. And for any scientific publication, you have to have dsDNA done by this very technique, which shows the bright immunofluorescence like this. The lupus band test was done for confusing pattern of skin involvement of lupus, where there are no other clinical manifestations of lupus, and if you have a rash which is just looking like a lupus patient, then you can use this band test, again positive immunofluorescence at the dermoepidermal junction, and you can diagnose only the cutaneous lupus in many patients. A vasculitis can again be diagnosed by pathological survey, and you can do the biopsy of either the nerve or a particular ulcer where the patient has got only vasculitis as a manifestation. The point to tell you all these investigations is that you are the boss for choosing the investigation. If it is only vasculitis, then you can perhaps use skin biopsy, or you can use other immunological surveying, whatever can lead to vasculitic manifestations. Kidney biopsy is something which we will always have some controversy, and I will deal about it later, but you know that alone kidney biopsy as a plain microscopy will not give you much knowledge. You have to sufficiently provide either immunofluorescence technique, or you have to do electron microscopy to see where are these immune complexes are deposited. And that is the area where the pathologist can burn their light the whole midnight to know whether the patient has got subendothelial deposits or they are mesangial-proliferative, and so on and so forth. So this is something where pathologist can always eat up your head to tell you the prognostication in a patient of lupus. So it has its own role in scientific studies and also to know the best from a patient of lupus. Having done the diagnosis, I will just tell you for diagnosing criteria of lupus. You know that the criteria of lupus are all clinical and they have to be supported by the lab test. The ACR criteria have designated 11 criteria for the diagnosis, and to receive a diagnosis you were always taught that you require 4 out of these criteria. Mind you that this particular thing is only for again scientific inclusion of your study. For day-to-day clinical practice, if you have got a childbearing or a young girl who has got fever, arthritis and a rash, and the patient has got ANA positive, you can still be holding your breath and saying yes, this patient would be having probably a lupus, even though the patient is not fulfilling all the criteria. But they make you wiser. You look for in other systems whether there could be any activity of lupus. What you would do in such a case is to do urine examination and see whether the patient has got albuminuria, whether the patient has active cast, and that will support your diagnosis of lupus. Or you can keep a close surveillance for the clinical manifestations and tell the patient to come for follow-up in case she develops fever, she develops rash, she has to come back and report to you. So high suspicion or a paranoid mind is required to diagnose a patient of lupus, and the patients can look exactly like rheumatoid or scleroderma, but they can jolly well go to actually the lupus. And these are the basic criteria, you all know about them: malar rash, discoid rash, photosensitivity. In our kind of complexion, it is little difficult to see the photosensitivity or allergy, but by close examination you can make out. The renal disorder is something which I would like to highlight, is that urine examination is extremely important. All these criteria, mind you, they do not exist in a patient at the same time. It means that over a particular period of 1 year, 2 years, or maybe many years, the patients can fulfill this criteria. That is why good medical record and a good history is something which is extremely important for diagnosing lupus. It has to be supported by positive anti-nuclear antibody, or you can do VDRL, or you can do anti-phospholipid antibody to support by the lab. Now we will come to the management. Why I thought is important to diagnose is that unless you have a good diagnosis, one should not embark upon giving the patient cytotoxic drugs and the drugs like steroids. So when you use a diagnosis, or when you are very much confirmed in the mind that you are dealing with a patient of lupus, yes, then it requires further comprehensive treatment from your part. Now for dermatological involvement, you know that there are many aspects of the skin. You can have up to 85% of the patients of lupus will have mucocutaneous involvement. It means that you have to see their oral cavity for presence of ulcers, you have to see the skin thoroughly to check whether the patient has discoid lesions behind the ear, inside the ear, or you can see erythema nodosum sometimes, you can see vasculitis, or you can see a very faint rash like livedo reticularis. It means that the malar rash as is seen in this picture, or the discoid rash which is seen in this picture, or this kind of catastrophic vasculitis is seen in only few percentage of patients. The other patients will have clinically soft signs, and the skill of a physician is not to miss these signs. This kind of alopecia is again very commonly seen in small areas, and the hair would be very brittle and they will lose the texture. This is one point of concern to most of the females, where they want to flaunt their hair growth, and they would come and say that they have got too much of hair fall recently, and they are worried about it, and that brings them to the physician. Oral ulcers are generally seen on the hard palate, but they can be also seen on the gums. The most important thing to avoid the skin manifestations is to avoid the sun exposure and the ultraviolet rays. You can use topical steroids, and for persistent skin rashes, systemic corticosteroids is a must. Many a times a drug which is a simple drug like hydroxychloroquine is not used in the clinical practice for the skin manifestations, and you know that in dermatomyositis as well as for the skin involvement of lupus, hydroxychloroquine plays a very important role. But it is not only the role in skin management. I would just like to point out that every patient who is confirmed with the diagnosis of lupus should receive hydroxychloroquine as a baseline drug. It not only prevents the skin manifestations, but it is really good for doing immunological modulation, and for also maintaining the remissions, and for also preventing thrombotic episodes. Hydroxychloroquine is a basic treatment for every lupus. People are worried about the ophthalmic toxicity of hydroxychloroquine. We generally go with 400 milligrams per day in the beginning, and maybe after 6 months or 3 months we can reduce it to up to 200. With hydroxychloroquine, the chances of macular toxicity as well as retinopathy are very less, and once in a year a good ophthalmic checkup is all that is required to prevent the ophthalmic toxicity. There are other benefits of hydroxychloroquine like lowering the lipids and prevention of thrombotic episodes, and that is why one must use it, one must not hesitate to use hydroxychloroquine. For Raynaud's also, you have to just tell the patient to avoid the cold exposure, and vasodilators can be there. For musculoskeletal system, which is again a very important aspect of lupus, you can use simple non-steroidal anti-inflammatory drugs. One must know that the lupus arthritis is little different than rheumatoid. You may get always most of the joints involved, the small joints of the hand. It's not only the second or third metacarpophalangeal, but you can get all PIPs involved at one time, and that really makes you suspicious about lupus. The most frequently involved joints are those of the hand, and sometimes you can get extreme fatigue. How do we identify lupus is that the manifestations are less, but the fatigue and pain is much more than the clinical manifestation. They can also get early morning stiffness. Sometimes this is a dangerous thing which occurs in lupus, and that is avascular necrosis of hips. And you know that it can happen with high dose of steroid or a small, not able to bear the weight on the hips. She has difficulty in walking. She is on steroids. Then please don't hesitate to do MRI, and don't wait for the signs like this, a radiological evidence of AVN. No, we don't want that. We want MRI to pick it up as early as possible, and the bone marrow edema would be one of the early signs where you can save the hip joint from disastrous consequences. So I have already told you that you can use NSAIDs, but you can also use leflunomide, and you can use hydroxychloroquine in resistant cases of arthritis. Steroids are very good for these arthritic manifestations, and a short course is always absolutely advisable for the patients of arthritis. Now we come to the major organ involvement of SLE, and the skin is not something which we are bothered about, but we are bothered about major organ involvement, and one of such things is neuropsychiatric involvement. Many times as a physician, you receive a reference call from a psychiatrist that the so and so patient has got abnormal clinical behavior, she has got mood disorder, she cannot concentrate, she is not so much interested in the studies, and she has got this kind of cognitive dysfunction when this is tested for MME scaling. And then if you go in the history, she would be telling you that she has got some history of rashes, she could be having some albuminuria, and she could be having some fever. So high suspicion again would tell you that neurological involvement could be there. Sometimes the presentation could be something like Guillain-Barré syndrome, like ascending or descending paralysis, and you can also have acute confusional states. You know that the two criteria for neurological involvement is psychosis and convulsion, but mind you that anything in neurology can get involved. You can get recurrent myelitis, optic neuritis, and you just name any condition like demyelinating disorders, and that can be the first manifestation of lupus. So the crux of the story is that for all the patients of young patients with unexplained kind of neurological manifestations of mood disorders, and also the signs like cord involvement, you should not hesitate to do anti-nuclear antibody and then support your diagnosis. You know that the brain nerve problems and psychiatric syndromes are very common, and that is why you have to have a very broad outlook for that. How do we deal with CNS lupus? Either it could be thromboembolic phenomena because of Apla syndrome, or it could be because of vasculitis. In case of vasculitis, you can get diffuse brain damage, you can get something like cerebritis, and which can be picked up by either MRI or the PET scanning, or you can do something like MR angiography to see the presence of vasculitis. And if it is a presence of vasculitis, then no matter whatever you do, you have to treat these patients with high dose steroids and immunosuppressants. You should not hold back your treatment. Many a times you do not get positive ANA report and many other lab tests, but high suspicion itself will make you deal with these patients more effectively, and you should use immunosuppressants and also steroids in such cases of high clinical suspicion. These are known as rheumatological emergencies. The seizures can be best managed by, of course, anticonvulsants and antipsychotic drugs. Coming to hemat kind of abnormalities, you know that RBCs, platelets and WBCs, all the three series can get involved, and you have pancytopenia as one of the manifestations. Remembering my teachers in my undergraduate and postgraduate days, they used to tell us that look at the patients of arthritis and look at their CBC count. In patients of rheumatoid, you always will get leukocytosis, whereas in case of lupus, if it's a first attack, you will get leukopenia. Also try to see lymphopenia as one of the manifestations which come along with arthritis, and that gives you a clue that this patient could be having lupus. So if you have got something like pancytopenia, you can definitely suspect lupus if the patient has arthritis along with it. Management of pancytopenia is not all that easy because you have to use again high dose steroids, azathioprine, dinazole, or sometimes intravenous immunoglobulin. For resistant thrombocytopenia, you can use even rituximab as a choice of drug because that has got very good results in case of immune thrombocytopenia. Thrombocytopenia as well as leukopenias can be because of other viral illnesses or because of sepsis. So before you transit into or embark into this kind of cytotoxic therapy, please try to correlate this with clinical manifestations, try to rule out sepsis, try to rule out macrophage activation in patients of pancytopenia with lupus, and then only you can possibly deal with these kind of drugs. So IVIgG has a very good role to play in all these patients, and I have already told you that anti-CD20 monoclonal antibody rituximab has a great role to play for resistant thrombocytopenia. So many times you are called from ICU because of this kind of massive pulmonary hemorrhages or catastrophic pulmonary events, and not just small things like pleurisy. Pleurisy is one of the commonest manifestation of lupus, which is known as pleuropericardial disease, and they can have a mild involvement of pleura, or they can have something like acute lupus pneumonitis. Pulmonary hemorrhages can make the patient go to ICU and they have got absolute hemoptysis, or they could be just a diffuse interstitial lung disease. It is very difficult then to diagnose lupus from non-infectious causes. So you have to again do ANA, you have to take the medical history and then see whether this particular patient, which looks like just a pneumocystis carinii or ILD, could actually be having a lupus pneumonitis. So again here high suspicion will play a role. Pericarditis, myocarditis is again very well known, but what you can get sometimes is Lippmann-Sachs endocarditis and valvular disease, and I have recently seen a patient who came with actually manifestations like a stroke, and on examination she had valvular murmur and she had Lippmann-Sachs endocarditis. She was not a rheumatic heart disease, but she was non-infective, or as we call it as NBT. In such a situation, again antiphospholipid antibody is something which you have to do for NBT, that is non-bacterial endocarditis, and try to use anticoagulants instead of only antibiotics. So pericarditis and pericardial effusion. In our country, when we deal with these cardiac manifestations or serological manifestations, what we have to rule out is presence of tuberculosis in these patients, because you know that the commonest cause of pericardial effusion or the pleural effusion is tuberculosis, and even in lupus the exudative fluid will make you feel that it is tuberculosis. In such doubtful cases, you have to give both the drugs, you have to give anti-tubercular drugs as well as you have to give steroids. Pulmonary hypertension is a very rare manifestation of lupus, and it can again be managed with not only vasodilators, but you have to use cytotoxic drugs along with vasodilators and bosentan, which has come as a new drug to deal with pulmonary hypertension. So I have already told you that in pleuritis and pericarditis you can easily use NSAIDs. You don't have to use cytotoxic drugs in all the patient, but with massive kind of serological involvement you have to use high dose of steroids with cyclophosphamide or azathioprine. Now, having said all these things, how do we monitor these patients of lupus? First is that it cannot be emphasized too strongly that lupus is a disease which requires regular follow-up. You have to tell the patient to come monthly or maybe 3 monthly, and you have to tell all these advice about avoiding UV light infections, and they have to be very careful, because the moment they become better they want to go out and eat some pani puri and bhel puri, and the first question they will ask me whether they can go for hoteling. You have to tell them proper precautions have to be taken. Many times anti-tubercular drugs have to be used as prophylaxis because we know that when we are using high dose of steroids, we cannot hold back anti-tubercular treatment, and there are many studies done in India wherein anti-tubercular prophylaxis in the form of Isonics as well as rifampicin are advocated in these patients. For grading the clinical activity, you have to use mainly clinical judgment, and the SLEDAI criteria are used for clinical studies for grading the activity of the lupus, and this is done in big rheumatological centers, that you use these scores, and any score which is beyond 4 or 6, you know that the patient could be having a very severe lupus, and you can protocol based your treatment. If you have got high SLEDAI scores, definitely the patients require high dose of steroids. And during the flare, the most important thing is mucocutaneous flares are extremely common along with other flares. So if you have got renal flare, you still will have some kind of a mucocutaneous flare coming up, and you can always suspect that you should do thorough clinical examination and kidney examination. The clinical therapy is the main group of drugs which are useful are steroids, anti-malarial as well as cytotoxic. One of the few aspects of lupus patients, because they are childbearing age, is the pregnancy, whether they can remain pregnant, how long they should take the drug, whether these drugs are toxic during pregnancy. And you know that if the patient's disease is not active, then that is the best time where the patient should remain pregnant. If the patient does have activity of a disease, it is always better to tell the patient that you should not embark on pregnancy, you should take the treatment, have the disease absolutely inactive, and then only you can undergo pregnancy. Use of prednisolone is that you can use only prednisolone, you should not use other synthetic things like betamethasone and dexamethasone. And patients who have got APLA positive, because they have got high risk of fetal loss, they have to be again monitored during the pregnancy for the presence of hypertension and thrombocytopenia. So these patients require close monitoring by the gynecologist for their APTT level, for their platelet level, and for the hypertension. And if they have APLA positive, you have to do anti-Rho antibody and La antibody for the presence of congenital heart block in a fetus. So again, coming to the APLA positive patients of lupus, you have to give low dose aspirin with prednisolone, and it has to be given right from the first trimester. Oral anticoagulants should not be used because they are teratogenic, and you have to use heparin. Either you can use regular heparin or you can use deltaparin. Screening for anti-Rho and La I have already told you. Infections are mainstay of the treatment. During the time where you are actually treating the patients of lupus, you have to continuously monitor them for the presence of infection, and any flare should not be mistaken from the infection. So you have to dissect the clinical scenario and treat accordingly. Last but not the least, and I have kept it purposely the last, is that the presence of renal lupus. All said and done, what morbidity you get from lupus is because of kidney involvement, and what you want to check is that the patient should not go to end stage renal failure, and patient should not require renal replacement therapy. Majority of the patients of lupus will have involvement of the kidney either in the form of asymptomatic proteinuria, or they will have flares like this. You know that the classification of lupus nephritis, and I will not go into the details, but what we can have is a symptomatic patient, or you can have presence of acute nephritis and acute renal failure, or the patients can come with nephrotic syndrome, or the patients can come with APLA with thrombotic microangiopathy. These are all the manifestations of renal lupus. There could be presence of severe hypertension with nephrotic syndrome, and what I would request you to keep it in mind, that whenever there is a patient who is a young girl who comes with first time the acute glomerulonephritis type of attack, you must suspect that there could be lupus. You must do the ANA, you must do the dsDNA along with so many other immunological things like for vasculitis, and then you have to closely monitor these patients. In patients of RPGN, that is rapidly progressive GN, you should not really wait for the presence of lab testing, but you should bombard this patient with intravenous corticosteroids and even cyclophosphamide. That is the only way to save their kidney. So these are some of the manifestations of lupus which I have already told you, and I have also told you that you can do the urine analysis. You can also take help of C3, C4, CIC because the complements will be reduced, and you should do APLA in all the patients of renal, because you know that the manifestations could be totally different and management can be different. Now, the biopsy is something which everybody will not like to do. They are young patients and they don't want any invasive procedures, but in doubtful cases you should do a biopsy, and they will tell you a lot about the prognostication signs. And these are some of the indications that you have something like diffuse proliferative GN you don't want to do because the patient already has got nephrotic range proteinuria. But if you have a low grade abnormalities and you are compatible for more than one diagnosis, then biopsy should be done, immunofluorescence should be done, and then you should subject the patient for something like good indices. And I will just come to the treatment, which is the last aspect, that you have to recognize early renal involvement. There are two aspects of the clinical management. One is that you have to induce remission and then you have to maintain the remission. This you have to do it by minimizing also the drug related toxicity. So induction, for these are the treatment options which you have, that you can go with corticosteroids or we can go with cyclophosphamide. Little bit brief about all the NIH trials, that cyclophosphamide emerged as the first line treatment for management of renal lupus, because the comparison was done between corticosteroids alone and combination of corticosteroids along with azathioprine and cyclophosphamide, and it was absolutely shown that intravenous cyclophosphamide given in monthly cycles is better than not giving cyclophosphamide. And that is why in all the patients with severe lupus you have to use cyclophosphamide as a drug of choice. Mycophenolate mofetil is now the second most common drug which is used in the practice, and that can be used both for induction and also for maintenance therapy. The cytotoxicity and cytopenias are less with mycophenolate, so are the other side effects like gonadal suppression and cytotoxicity or other cancer occurrence, and because of that mycophenolate is chosen over cyclophosphamide for even for induction. Lots can be said about the renal lupus, but I think that this is not the right platform to discuss only on the renal lupus. Those people who have questions on renal lupus, I will be glad to answer them, but what I will be trying to tell you is that for the maintenance therapy now, not only the cyclophosphamide, azathioprine and mycophenolate are available, but we are using lot of other biologics, as Dr. Dharmanan has pointed out. Drugs like rituximab, drugs like abatacept, anti-CD20 monoclonal antibody and humanized monoclonal antibody, all are in the trial now, and I am sure that within few months or maybe within a year you will have lot of data which definitely tells us that we have many more drugs than cyclophosphamide alone for treating lupus nephritis. I think so that for renal lupus you have to refer the patient to nephrologist, and there would be a combined consultation from the nephrologist and the rheumatologist, because patients can have more than one system involvement, so this requires really a teamwork. So treating lupus is not something like treating one disease, it can have varied manifestations. All the faculties of medicine require their heads to be put in, and you require not only just the treatment but rehabilitation, continuous consultation and preventing the side effects of all these potential cytotoxic drugs like lipid profile, hypertension, and preventing the cardiac manifestations which can be absolutely disastrous at the end of the day. I think so I have told you most of the things in management of lupus, and I thank you all for your patient listen.
Thank you, Dr. Jyotsna. Any questions from the audience? Inviting.
Hello, Dr. Jyotsna.
Yeah.
It's a very interesting talk. I just wanted to make one point for the sake of audiences, this thing, that only mild or moderate leukopenia of say 2,500 or 3,000, when it is not accompanied by severe thrombocytopenia or hemolytic anemia, may not need aggressive treatment.
Yeah, that's right.
Yeah.
Actually, I have not gone to the gradations of the treatment for cytopenias, but of course it is definitely goes without saying that if the patient has got mild cytopenias, then it doesn't require treatment. It's only in patients who have got counts which are less than 1,500 or 2,000 Then systemic steroids, you can use either 0.5 to 1 milligram per kg, and that too you have to monitor along with the response of the patient. I was telling cytopenias as one of the signs whereby you can diagnose lupus.
But only with the presence of leukopenia, your suspicion of a flare should be quite high.
Yeah, with presence of arthritis or arthralgia.
There are no more questions. We move on to the next speaker.